I think, do we need to unmute through Zoom? Yeah. Okay. My name is Tylen DiGiacomo. I am the current PGY2 in critical care, and I'm excited to present a unique CE topic today titled The Truth is in the T Cells, Managing Secondary Hemophagocytic Lymphohistiocytosis. Nor my mentors or I have anything to disclose. And by the end of the presentation today, hopefully we all should be able to describe the proposed pathophysiologic mechanisms of adults with secondary HLH, define available diagnostic criteria for these patients, and finally review current primary literature, pharmacokinetic, and patient-specific considerations for the treatments of adults with this disease state. I have additionally included abbreviation slide here for your review. So, hemophagocytic lymphohistiocytosis, which I will now be referring to as HLH through the remainder of the presentation, is characterized by a severe hyperinflammatory syndrome caused by overactive macrophages and cytotoxic T cells. There are two types of HLH, primary and secondary, but what I want us to understand is that these are fundamentally two different disease states. Primary HLH is more prevalent in children. It is genetically based, and its etiology is secondary to the studied mutations that I've listed on the slide that lead to subsequent lymphocyte and natural killer cell dysfunction. Secondary HLH is more prevalent in adults and is a lot more nebulous. It's thought to be caused by an externally provoked clinical diagnosis secondary to hyperinflammation, but the key difference is there's no demonstrable genetic cause. One key thing about secondary HLH is that mortality rates are rather high, 20 to 40% mortality within the first 30 days of diagnosis. So we discussed that secondary HLH is thought to be caused by an exogenous triggers. These are often implicated by infection, autoimmune disorders, malignancy, and iatrogenic cause. Most often are immunomodulators. So starting with infection, our most common cause, it's thought to be attributed up to 50% of all HLH cases, most associated with Epstein-Barr virus, cytomegalovirus, or general bacterial infections. Autoimmune disorders, the most common autoimmune disorders we typically see with HLH are adult onset Still's disease, systemic lupus, and juvenile idiopathic arthritis. Malignancy is another common cause of secondary HLH. It accounts for about 28% of cases. Most commonly, this is going to be associated with your lymphomas, followed by leukemias, and more rarely are solid tumors. And then finally, we have iatrogenic HLH, which is often implicated by immunomodulators. So we'll be talking a little bit about those later in the presentation, but most commonly, this is going to be our PD-1 inhibitors, CAR T-cell therapy, and BiTE therapy. But before we talk about the exogenous triggers, I want to lay the groundwork for the proposed pathophysiology for both primary and secondary HLH. So what we're going to do is take a trip back to biochem. What you're looking at here, if I can get my laser pointer on, is the interaction between the natural killer cell and its target cell. Normally, the Golgi apparatus is responsible for the sorting and packing of these cytotoxic granules, perforin and granzymes A and B. They travel through the cell and end up at these proteins that are responsible for docking to the target, where perforin can literally perforate the target cell and allow the granzymes to enter into the target to induce apoptosis, therefore eliminating the target cell. However, in primary HLH, due to loss of function mutations from that implicated genes that we saw on the first slide, perforin is not made or not made in high enough quantities. Therefore, we can't perforate the cell and allow the granzymes to induce apoptosis. So that's the groundwork for primary HLH. Secondary HLH, like I said, is a lot more nebulous. What we discussed in primary is this process right here. However, in secondary HLH, instead of a genetic mutation, the underlying etiology is thought to be caused by some highly immunogenic trigger. So that's whether it's infection, malignancy, or rheumatologic disorders. But between the two, the end result is the same. What we see is a dysregulated immune system unable to restrict the stimulatory effects of the trigger. So we have cytotoxic T cells and natural killer cells failing to eliminate their trigger. They will continue to replicate due to the persistent antigenemia. Regulatory T cell numbers will drop, and cytotoxic T cells will continue to proliferate. So as a result of this, the cytotoxic T cells are going to produce massive amounts of interferon gamma that lead to excessive macrophage production and hemophagocytosis. These macrophages release large amounts of pro-inflammatory cytokines. This includes things like our interleukins, creating what is often called a cytokine storm. So due to these ongoing cycles of inflammation, cytokine release leads to end-organ damage and an overall septic-like presentation. Because similar to septic shock, all of these inflammatory cytokines can lead to leaky vessels and overall a vasodilatory shock-like presentation. So with that, let's talk a little bit more about the more phenotypical presentation of adults with secondary HLH. Like I said, this manifests as a sepsis-like critical illness. Fever is present in almost all cases of HLH. Neurologic symptoms occur less often in patients with secondary HLH as opposed to primary, but is still common in up to 25% of cases. This will often present as seizures or general encephalopathy. One key thing that I do want to point out is splenomegaly and hepatomegaly. This is thought to be due to infiltration and accumulation of activated immune cells and inflammation. Looking at our laboratory findings here, one of the most common things we'll see in HLH is cytopenias as a result of significant hemophagocytosis. Additionally, we see marked hyperferritinemia in these patients. This is thought to be due to increased free hemoglobin that's associated with erythrophagocytosis. So therefore, we have more more ferritin secreted from our body to try to sequester the excessive free iron. Hypofibrinogenemia is also common. Coagulation disorders will occur in up to 60% of all HLH cases. Macrophages secrete pro-inflammatory cytokines like we discussed, one of those being TPA or tissue plasminogen activator. Therefore, more plasmin leads to more fibrinolysis. Hence, DIC is a common complication of HLH, but this can also be a complication of sepsis as well. The last laboratory marker that I think is unique and relevant to talk about is hypertriglyceridemia. This is thought to be due to increased TNF alpha, leading to decreased lipoprotein lipase activity. So that brings me to our knowledge assessment 1. Secondary HLH is thought to be caused by a genetic mutation leading to decreased perforin, B, an exogenous immunologic trigger, or C, dysregulated feedback loops between T cells, natural killer cells, and cytokines. Or D, both B and C. Yeah, so the answer is D, both B and C. Secondary HLH is more prevalent in adults and is thought to be implicated by some type of exogenous trigger that leads to that subsequent dysregulation in our T cells and natural killer cells. So I want to make this a little bit more real world and maybe relate it to a patient that you've probably seen before. So this is a real case that I'm presenting on. I have the reference down in the bottom part of the slide. This is a 20-year-old male that presented to the medical ICU with multi-organ failure and undifferentiated shock. His chief complaint is a 1-week history of shortness of breath and flu-like symptoms, and his only past medical history is IV drug use. So if I get this patient into my ICU, one of the first things I want to start working up is supposed infection. So he's presenting with that 1-week history of shortness of breath and flu-like symptoms. I want to make sure that we test for the flu, test for COVID, or any viral things that we could rule out for this patient. Obtaining blood cultures, getting our chest x-ray, and then knowing that he has a past medical history of IV drug use, I would want to look at anything that would predispose him to other types of infection like HIV, hepatitis B and C, and then depending on what the blood cultures show and its due criteria, looking at endocarditis. But what we saw is that all of that was negative. So if this presentation was not about HLH, would this be your first suspicion? No, right? And it shouldn't be. For patients that present in vasodilatory shock, we should be doing appropriate infectious workup. So here we are on day 3. Our patient is continuing to deteriorate despite aggressive fluid resuscitation followed by vasopressor support. He is currently on broad spectrum antibiotics, receiving both MRSA and anti-pseudomonal coverage. He's being optimized with invasive mechanical ventilation. So at this point in our workup, we've likely consulted infectious diseases. This is where Kyle and Mitch may look at some of those less common immunocompromised infections. They may even send for a Karius. From a MICU perspective, we're looking for other things that could be confounding in his presentation, maybe sending for an autoimmune workup. A lot of these things take a little bit longer to come back. So what we do is we send for anti-DNA antibodies, ANAs, and some of our complement levels. The only imaging that we have as relevant for this patient is hepatosplenomegaly, and some key lab abnormalities of interest are marked hyperferritinemia. I have our reference values on the side for us. We have an elevated LDH, leukopenia, and thrombocytopenia. So while we wait on some of those send-out labs to come back, let's go ahead and talk about diagnostics. Lucky for us, the Histiocyte Society has a work group that focuses on HLH in adults with the aim of reducing both morbidity and mortality for these patients. So their recommendation for diagnosis is, I don't know why that stopped. Uh-oh. Sorry about that. Their recommendations for diagnosis is that it should be based on the HLH 2004 diagnostic criteria with clinical judgment and the patient's history. So this has a strong consensus, meaning that more than 95% of participants agree. So that begs the question, what is our HLH 2004 criteria? This criteria was not based on any real-world experience, but rather the inclusion-exclusion criteria of a single pediatric clinical trial. This was never designed to help or diagnose adults with secondary disease. What we can see here is that number one is a molecular diagnosis consistent with HLH. A lot of times due to severity of illness or with the cytopenias, getting something like a bone marrow biopsy is potentially inappropriate in this patient population. We also have diagnostic criteria that they lay out saying that you must meet 5 out of the 8 to be positive. So let's look at some of these. It's a lot of the things that we've already talked about, overall very non-specific, including things like fever, splenomegaly, hypertriglyceridemia, and hypofibrinogenemia. But let's keep going down the list. Low or no natural killer cell activity. Has anyone ever ordered that lab test before? No. Soluble CD25. No. Yeah, so these things are going to be send outs and oftentimes not available for a lot of institutions and not very feasible. And that to say, getting something like a bone marrow biopsy is not even required for diagnosis and is very invasive. So now that I've filled you with confidence about our HLH 2004 criteria, we also have another tool called the H-score. This was developed by a French physician by retrospectively analyzing adult cohorts of ICU patients. So we see a lot of the same concepts here, but with one great addition, that is known underlying immunosuppression. So since this was developed by and for adults, we can see that an exogenous trigger is being considered here, such as malignancy. Number of cytopenias, what we're doing now is we're now differentiating between the degree of some of these symptoms. So we now have different scoring points based off the number of lineages of many of these things. They dictate that immunosuppression is defined as patients with HIV or on any long-term immunosuppressive therapy. And they define cytopenias as a hemoglobin less than 9, white blood cell less than 5,000, or platelets less than 110,000. So if you're like me, you probably think that these scoring criteria aren't really going to help you diagnose your patient. So the first study that I'm going to be presenting today was published in 2020 in Critical Care, and that looks at the diagnostic reliability of patients with both the HLH 2004 score and the H-score. It was a retrospective observational study conducted over 2006 to 2018 that included adult ICU patients with clinically diagnosed or suspected HLH. And one unique thing is that they dictated that the patients had to have some degree of hyperferritinemia, but if we remember, that was not required for diagnosis based on either of those scores. So to orient you to this table here, essentially what they did was they decided among an expert panel of retrospectively looking at cases, they decided that 40 patients had HLH. They then compared those to about 2,500 patients who didn't have HLH and tried to see if these scores were reliable. Looking at their baseline characteristics, there was just a couple things I wanted to point out. The first one being septic shock. We've already talked a lot about the clinical overlap between HLH and septic shock, so I feel like that is represented here. In our HLH cases, we can see that 57% of patients had this compared to 24% in the non-HLH cases. Additionally, immunosuppression. 75% of patients in the HLH cases had immunosuppression, whereas only 28% did in the non-HLH cases. Moving down the table, we can see that their HLH 2004 criteria was 5 in the HLH cases, which makes sense, and an H score of 258. So here are their results. To orient you to this table, essentially what they're doing is looking at the sensitivity and specificity based off the cases versus controls. What we see here is that the HLH 2004 criteria had the highest sensitivity and specificity at a score of 4, which is lower than what's traditionally accepted. And for the H score, it had the highest sensitivity and specificity, so 100% and 94% respectively, at a score of 170. So what we learned is that, not any surprise to me, the H score had a slightly superior prediction accuracy. So I like this study because it was the largest study in the adult population that evaluates the diagnostic accuracy, which was previously very understudied and continues to be understudied. I love that they included things that we're probably not going to be able to rule out, including sepsis and septic shock in these patients. However, this was a retrospective study. You don't have to have hyperferritinemia to be included for one of these scores. And I think what we learned is that you risk underdiagnosing your patients if you're using these stringent criteria like a score of 5 or a score of 170. But the biggest question I have for this panel that decided on the HLH cases is what resources they were using to do that. So these are the only 2 scores available that I know of, and I'm sure they know as well. So it may introduce some type of internal bias when they were deciding which cases had HLH and which ones didn't. So all that to say, my big takeaway for the diagnosis is that you can still diagnose secondary HLH without having filled all of your criteria. Just to summarize, the HLH 2004 criteria, they say that you should meet 5 out of 8, but I want you to just remember that this is extrapolated from pediatrics. It was never meant to diagnose adults. Additionally, we're going to say that an H score of greater than 170 is a positive score, and I do like this that this one takes into account more things that would be more applicable for adult patients. So I recommend doing these 2 criteria in addition to clinical judgment and a patient's history. We talked a lot about this overlap between sepsis, septic shock, and HLH. Will there ever be a time that we can differentiate between the 2? So one thing that I'm presenting is pretty experimental. It's still not clinically applicable, but it's looking at T cell activation profiles to help differentiate between early sepsis and HLH. So if we think about those clinical and laboratory criteria, almost all of it's nonspecific and can be explained away by critical illness. So fever of unknown origin, present in over 90% of adult cases. Cytopenias, while present in most HLH cases, is going to be developed in up to 70% of all ICU patients anyways. Hypofibrinogenemia, often caused by DIC. So this graphic that I'm showing you here is from a study that was conducted among pediatrics in Texas and Arizona. It only included 62 patients, but they wanted to distinguish T cell phenotypes. What they did is analyze the flow cytometry of kids that both met severe sepsis criteria and those that met the HLH 2004 criteria, in addition to a control. So by obtaining these pre-treatment samples, they found that these kids had distinctly more CD38 or CD8 T cells in the HLH group. However, this is only just now confirming some sort of correlation, both in animal models and pediatrics, and a lot of it is not yet clinically actionable. But my hope and goal is that we'll be able to have T cell activation profiles attainable in a much less invasive and easier to access way. So that brings me to knowledge assessment 2, which is not a component of the HLH 2004 criteria. Is it A, splenomegaly, B, hypertriglyceridemia, C, known underlying immunosuppression, or D, hyperferritinemia? I'm using this as my water break. The answer is C, known underlying immunosuppression. So if we think about the difference between the HLH 2004 criteria and the H score, known underlying immunosuppression was one of those great additions that was more targeted towards our secondary HLH patients. The rest of this presentation is going to be on the treatment of HLH. So I'm going to go back to the Histiocyte Society guidelines, and then the rest of it is going to be differentiating between these different subgroups of HLH. So back to our friends at the Histiocyte Society, their recommendation for the treatment of HLH is by using the HLH94 treatment components, including etoposide, as they say they are highly effective in treating hyperinflammation with adults with this disease. Again, this was another strong consensus, meaning that greater than 95% of participants agreed. But if you read the fine print in their recommendations, they kind of backtrack and they say, we recommend against a one-size-fits-all picture for these adults. So that leaves both a lot of gray area and a big positive evidence of how we should be treating these patients. But since they talked about the HLH-94 protocol, let's go over that study. This study was published in 2002 in Blood, and this is the treatment of HLH with this protocol for getting them ready essentially for bone marrow transplantation. This was a prospective clinical trial conducted from 1994 to 1998. This was a pediatric trial that included both primary or familial HLH, or any patient that fulfilled the diagnostic criteria from the Histiocyte Society. So the HLH 2004 criteria wasn't around yet, so I'll show it for completeness sake, but it's overall very similar than what we've already talked about. They excluded patients if they had any previous cytotoxic or cyclosporin therapy, and additionally excluded patients if they had any known underlying malignancy or autoimmune processes. So thinking about extrapolating this to our adult population, that already knocks out a lot of patients. For outcomes, they look at both survival and survival to bone marrow transplant. Overall, their study aim was to induce and maintain a state of resolution of the disease to ultimately cure either primary, persistent, or relapsing forms by stem cell transplant. This is the diagnostic criteria for completeness sake, but we can see here that overall it's very, very similar to the HLH 2004 criteria. This is the HLH-94 treatment protocol. This is their initial therapy. So this therapy spanned from weeks 1 to week 8 and included both etoposide and dexamethasone. Starting with etoposide, they recommended through their protocol dosing at 150 milligrams per meter squared 2 times a week over the first 2 weeks. So let's take a second to talk about etoposide. Etoposide is a topoisomerase 2 inhibitor, and its role in HLH is thought to selectively deplete our TCD8 cells. As we've talked about, this is the primary implicator in its pathophysiology. Looking at the dosing from the protocol, there's a lot of other things we need to take into account when we're dosing it in these patients. The first is cytopenias. So we would want to withhold doses of etoposide if your ANC is less than 500 or if your platelets are less than 50,000. Additionally, there are dose adjustments for both hepatic and renal dysfunction. With hepatic dysfunction, dose adjustments starting at a bilirubin of 1.5 or an AST of 3 times the upper limit of normal. And renal dysfunction starts at adjustments of creatinine clearance of 50 mLs per minute. Overall, from a pharmacokinetic standpoint, it has poor blood-brain barrier penetration. It's primarily hepatically excreted. And from its side effects, we know that it causes pretty severe myelosuppression. So a lot of these patients are going to have cytopenias anyways. This has a very high risk of leading on to sequelae such as infection or secondary malignancies, specifically our acute leukemias. However, it is dose-related and dose-limiting. Expected hematologic recovery occurs around day 20. And then other adverse events to keep in mind are both alopecia and GI upset, including nausea, vomiting, and diarrhea. So back to our protocol, we've talked about etoposide. Our next component is dexamethasone. They started a dose of 10 mg per meter square, and then they tapered that by essentially cutting it in half every 2 weeks and dropping off completely after that week 8. We're probably all a little bit more familiar with dexamethasone. This is a long-acting glucocorticoid, and its role in HLH is to suppress the production of those inflammatory mediators. I am not accustomed to dosing things in BSA, or I don't do it often, so I wanted to provide an example. So this is a 5'10", 90 kilogram patient. So his BSA is 2.08, and if you use that, that comes out to about 20 milligrams. What we know about dexamethasone is anything greater than 10 grams should really be put in IV piggyback for risk of irritation. So what we have here is what's in our Erlanger order set. So putting it in 50 mLs of normal saline and giving that over 15 to 30 minutes. As for monitoring, I could have put 40 things here, but I wanted to put my top 3, and that's hyperglycemia, adrenal suppression, and GI hemorrhage, where you could probably make a case for stress ulcer prophylaxis. So going back to our protocol, like I said, they'd cut that dose in half and have that eventual taper at week 8. So if that worked, they decided if that worked by comparing it back to that Histiocyte Society criteria. They considered therapy complete if it was secondary disease. If it was primary disease or unresolved secondary disease, they got these patients ready for bone marrow transplant. So this is the protocol. If you kind of back it up, what I focused on here was that initial therapy, but that continuation therapy for patients who either didn't resolve or had primary disease is more applicable to the pediatric population, therefore is really out of the scope of this presentation. So I'm not going to go over the additions of cyclosporin and all of the conditioning they did to get ready for bone marrow transplant. So let's go ahead and talk about the results of this study. Looking first at their baseline characteristics, we can see a median age of about 24 months in among all of the patients. Looking at the chart as a whole, they've separated the results of the primary or familial cases versus all. So all the patients they included 249, this is where our secondary disease patients are going to fall into. First, looking at alive without stem cell transplant, 21% of patients in the population met that. 71% of patients were admitted to stem cell transplant or alive without it. And cumulative 5-year survival was 72.5%. So the takeaway is the HLH94 treatment protocol led to a major improvement in the pediatric primary HLH patient population. They decided that it was effective in inducing remission and cure in 54% of the patients. Altogether, 71% of these patients were successfully treated by this protocol. So they either went on to receive transplants or achieved long-term remission just through that initial protocol. The only problem is that this isn't our patient population. So I think the study did a lot of things well. I like that they had a clearly defined study protocol and that they delineated the treatment based on whether you had primary or secondary disease. However, I think things that limit its applicability to our patients is the exclusion of malignancy or any other autoimmune processes. Additionally, only a small subgroup of these patients had secondary disease. So that brings me to knowledge assessment 3. What factors should be considered prior to administration of etoposide therapy in adults with secondary HLH? Is it A, the degree of cytopenias, B, renal dysfunction, C, hepatic dysfunction, or D, all of the above? The answer is D, all of the above. In adjunction to this, we should also be considering the patient's fitness as a whole. One thing that our adult patients have that our pediatrics usually don't is an extensive list of comorbidities, and their fitness overall is going to be a lot worse than what we saw in the HLH94 study. So the remainder of this presentation, we're going to be going through the different subgroups. The first one that I'm going to be talking about is MAS HLH or macrophage activation syndrome. This one is most associated with underlying rheumatic disorders. There's no current validated classification for the specific subgroup, but we do know that it's most associated with adult onset Still's disease, juvenile arthritis, and lupus. Just like in adult onset Still's disease and juvenile arthritis, a lot of the implications for these disease states are overamplification of T cells. So one study that I'm going to be talking about just briefly was conducted at Mount Sinai to try to characterize what they're doing for patients with HLH at their institution. This was a retrospective study evaluating the use of anakinra in adults. It included 16 patients and included all etiologies of HLH, so patients that had malignancy or infection as well. But they were able to include 4 cases with rheumatic disease. Their average total daily dose of anakinra was about 350 milligrams per day with frequencies up to every 6 hours. But a lot of them also received other therapies, including steroids, etoposide, and ruxolitinib. What they saw is in their overall survival group, it was 31%, but they saw this huge uptick. I say huge, it was 4 patients. They saw this huge uptick in their overall survivals in that specific subgroup up to 75%. So this sparked a lot of conversation about the utility of anakinra in this specific subgroup. Anakinra is an interleukin-1 receptor antagonist, and it's thought to help target some of that cytokine storm. For dosing, specifically in HLH, you start with about 2 milligrams per kilogram per day up to 8. And it can be given either sub-Q or IV, whether that's intermittent or continuous infusions. But one thing I challenge us as pharmacists to consider is the absorption that can oftentimes be variable given sub-Q routes in critical illness. We usually prefer IV routes if we have high doses, so really greater than 2 mg per kg, which is the starting dose here, to avoid pain from multiple daily injections, but overall to avoid erratic absorption as well. We know that in obese individuals, anakinra has a longer half-life. So in patients with greater adipose tissue, you have slower anakinra transport and ultimately less rapid systemic absorption. In terms of monitoring, we think about infection due to immunosuppression or sequelae from that. You can have injection site reactions with the sub-Q dosing, and it can cause neutropenia. In terms of renal dose adjustments, there has been proposed adjustments starting at every other day dosing. However, oftentimes in our HLH studies, we don't dose reduce this at all. So let's look at an anakinra study. This was published in 2019 in the Journal of Intensive Care Medicine. It looked at giving anakinra, intravenous immunoglobulin or IVIG, and corticosteroids in critically ill patients with HLH. This was a retrospective observational study from 2014 to 2016 that included adult patients that had suspected HLH based off the consensus of the care team. So this included things like oncologists and rheumatologists as well as their intensivists. For clinical outcomes, they looked at survival to ICU discharge, survival to hospital discharge, and safety. What I love about this study is that they didn't mandate that they had to have all 5 of the HLH 2004 criteria. They specifically said in their methods that none of them obtained a soluble CD25 level or natural killer cell activity given the feasibility. So it makes it really real world and probably what we would see in practice. The only downside of having a real world study is the protocolization of a lot of these things. So what they decided to do is they gave anakinra an average of 100 to 200 milligrams 3 times a day. They gave prednisone anywhere from 250 to 500 via pulse dosing, and then dosed IVIG up to 1 gram per kilo per day for 3 to 6 days. There was no standardized duration of therapy, which is a downside, but on average, anakinra was given anywhere from 5 to 21 days based off clinical response, and IVIG was consistently given around a 3 to 5 day duration. Looking at our baseline characteristics, these are all small studies, you guys. It has 8 patients included. Mean age was 39 years old. And then malignancy HLH accounted for 38% of the group. But their H score was positive without even trying. So remember, 170 is a positive score. These patients had a median of 213 and 5 on their HLH 2004 criteria. These patients were also pretty sick. They had a median SOFA score of 8. 88% were receiving invasive mechanical ventilation. 2 patients were on ECMO, and 88% were receiving some type of vasopressor support. Looking at the outcomes in this study, what we saw is that the median change in SOFA score decreased by 2.5 points, and survival to hospital discharge was 50%. Now, taking into account this is only 8 patients, half of them survived, but I think taking into account their critical illness at baseline, these are actually pretty good numbers. So I love that this study focused on critically ill adult patients and allowed for a really real-world pragmatic approach to adults with secondary HLH. However, it's a small retrospective study, and they could have done a better job at dictating or having a better, clearer way to understand the durations of what we're giving our patients. But given the spark and kind of the ramp up that anakinra is getting in this patient population, what I'm showing here is a future study that's currently being conducted at UAB looking at the treatment of MAS in patients with anakinra. And their hope is to better characterize anakinra's benefit and ultimate place in therapy with MAS HLH. So they're giving anakinra up to 10 milligrams per kilogram per day with methylprednisolone and seeing if that has any effect on mortality and infection. So that concludes MAS HLH. The next one that I'm going to be talking about is MAL HLH or malignancy associated HLH. This is, like I said, one of the most common types of HLH. Up to 70% of all cases are malignancy associated. There are 2 major subtypes. The first is malignancy triggered, and then the second is immunotherapy HLH or caused by your immunomodulating agents. As we discussed, malignancy triggered is often implicated by lymphomas and leukemias, and immunotherapy is due to things like CAR T and BiTE therapy. So our general recommendation is to try to balance the HLH-specific treatment with the cancer-specific treatment. Questions to consider in these patients is, will the treatment of HLH, so if I give etoposide to somebody who has cancer, is that going to delay their cell count recovery until I can actually treat their underlying cause, which is malignancy? Or is the progression and severity of HLH going to preclude the treatment of your malignancy? So There's no prospective clinical trials on the treatment of this. And I would say etoposide probably has the most controversial use here, but there's three proposed options that I'm going to provide today. Option one is just giving high-dose corticosteroids per the HLH94 protocol, that dexamethasone taper that we saw, while treating the underlying cause, which would be your respective malignancy. Option two is incorporating etoposide into traditional chemotherapy regimens. I think this one's my favorite because you're kind of triggering both at the same time. So an example that I have is we said that malignancy triggered is oftentimes associated with lymphoma. So for non-Hodgkin's lymphoma, there's already an approved treatment regimen called R-EPOCH. The E stands for etoposide. So going out of your way to choose treatment regimens that have etoposide already incorporated. And then finally, what you could do is give your HLH94 protocol, hope their counts recover so that you have enough time to actually treat them for their malignancy as well. Moving on to our immunomodulating therapy, HLH. First one we'll be talking about is CAR T cell therapy. I'm not very familiar with CAR T cell therapy. I've only seen it a couple times. So to introduce it to the group, it's chimeric antigen receptor therapy, and essentially its goal is to reprogram your patient's T cells to attack a specific antigen. So what they do is they collect blood. Let me get my laser pointer. They collect blood and they harvest your T cells and then introduce them to the specific antigen that they want them to have. So for example, in B cell malignancies, you can reprogram a patient's T cells to attack CD19. You can grow them out and then reinfuse it back to your patient. So that way, when they have these T cells, they now have the appropriate immune activation to target that malignancy. And as you can imagine, this causes an overdrive of your T cells. Similarly, with BiTE therapy or bispecific T cell engager therapy, very similar to CAR T, but without all of the external manipulation of your T cells. The example here that I provided is with blinatumomab. So what this does is it binds to your T cells at CD3, and then it binds to the leukemic cell at CD19 and forces them to interact. So the T cell is being forced to recognize this antigen. And then essentially that's what causes the proliferation and activation of all of these cytokines to then start fighting the malignancy. But what you can see is that this causes significant immune overactivation. This has also been noticed by other places and people that commonly do CAR T cell therapy. So what I'm showing you here is an image that's from 2023 in a bone marrow transplant study. What they saw is that cytokine release syndrome is an often overlapping syndrome that occurs pretty immediately after we give some of these immunomodulating therapies. Usually presents with fever, hypotension, and hypoxia. Usually give glucocorticoids or tocilizumab depending on the severity, but it typically resolves in about a week. Immune effector cell HLH is what they've deemed the cause secondary to these immunomodulating agents. They say that this usually occurs later, so around the 7 to 18 or 28-day mark. So the transplant panel suggests that you can call this IEC HLH if they have symptoms of mass HLH secondary to one of these drugs, and it's associated with the progression of cytopenias and hyperferritinemia, things that you couldn't say are attributable to the CRS. So while these HLH-like manifestations are frequently seen in patients with severe CRS, this is what differentiates them as the delay in this presentation. So this is the same group. They have treatment recommendations of their own. Starting with first-line therapy, they recommend anakinra plus or minus steroids. And after that, if that doesn't work, you can either increase your dose of anakinra or add corticosteroids or ruxolitinib, which we'll talk about momentarily. Third line, then and only then are they considering things like low-dose etoposide. So one thing to consider here is like you could potentially kill all of your hard-earned or reprogrammed T cells. So we'd really want to avoid that in a lot of these patients. So moving on, they mentioned ruxolitinib. This is a kinase inhibitor. It targets both JAK1 and JAK2, and its role is to block downstream transduction of the JAK-STAT pathway, attenuating the action of multiple key inflammatory cytokines, including our interleukins. The study that I'm going to present dosed ruxolitinib based off a 28-day cycle. So they started at 5 milligrams 2 times a day, increased their dose every 7 days to a target of 20 milligrams twice daily. Unlike the package insert, this study did not dose adjust anything for liver or renal impairment. And some key things that we would want to keep in mind with ruxolitinib, it does come with a thrombosis risk, can cause hematologic toxicity, but maybe not to the degree that we see with etoposide. Can also cause infection and hypertriglyceridemia. So let's look at a study that uses ruxolitinib. The first one is published in 2024 in CritCare Exploration that looks at ruxolitinib, IVIG, and high-dose glucocorticoids. This was a single center observational pilot study, and it was conducted over 2018 to 2023. This included adult patients admitted to the ICU, and they had to fulfill at least 5 of the 8 of our HLH 2004 criteria. And their primary endpoints were survival at 6 months, the dynamics of HLH-related biomarkers at day 10, so this includes things like your serum ferritin levels, and any safety endpoints. Overall, they really wanted to investigate using less toxic therapies than as seen in the HLH-94 protocol. This is their treatment protocol. So we've already talked about that ruxolitinib ramp up, but what I want you to see, you probably recognize this dexamethasone taper. It's just like the one that was in the HLH-94 protocol. They gave 20 milligrams BID of ruxolitinib and just continued this indefinitely until disease progression or unacceptable toxicity. There were no uniform instructions on discontinuation or taper. For IVIG here in the middle, we can see it was given for about 5 days and then 1 dose on weeks 2 and 3. For the package insert, you will see that ruxolitinib should not be crushed. However, this study did crush ruxolitinib for our critically ill patients and gave it via NG. So to guarantee correct absorption of ruxolitinib, they used prokinetic medications like erythromycin and then monitored residual gastric volumes. So the package insert says it can't be crushed, but from the study, we know that it can be safely crushed. Looking at their baseline characteristics, again, another small study, only 9 patients. We can see that the median age was 43 years old, and they did have a positive H score at 299. It's a pretty wide range of the types of HLH, including Epstein-Barr virus, malignancy, and infectious causes. And then these patients were also pretty sick. They had a median SOFA score of 9, which corresponds to about a 50% mortality rate in general without the HLH. With vasopressor support, accounted for about 44% of patients, and 44% were invasively mechanically ventilated, and 1 was on ECMO. Looking at endpoints for these patients, we can see that 100% of patients had survival to ICU discharge, which is pretty impressive to me given the baseline characteristics of the patients in general, given their critical illness. Additionally, 6 months, 86% of patients survived. And you'll see the major bleeding event was 1 patient. That was the patient that expired. It was secondary to an unrelated fall. They followed these patients for 18 and a half months, and they also saw a statistically significant decrease in those laboratory markers, including ferritin and those interleukin-2 levels at day 10. So I think that they introduce a really compelling, given the 8 patients, really compelling, less toxic alternative to etoposide. I like that they focus on critically ill patients, and it does offer an alternative to the HLH-94 protocol. However, we have to take in mind the sample size, and there's no comparator. But this is sparking a lot of discussion. There's other things like RuD regimens, so that's ruxolitinib and dexamethasone again. They're proposing 8-week protocols, very similar, combining that dexamethasone and the ruxolitinib. And they saw 2-month survival of 64% and an overall response rate of 85%. This was studied among patients with MAS, EBV, HLH, and malignancy associated, and they didn't have any toxicities that led to dose reduction. So I think that overall, our data is trending to where we would honestly prefer less toxic regimens in these patients. The last subgroup of HLH that I'm going to be talking about is infectious HLH, specifically Epstein-Barr virus HLH. Epstein-Barr virus is a ubiquitous herpes virus that infects nearly everybody worldwide without serious sequelae. It's most common in Asia, and what we know about it is it's a really common trigger of secondary HLH, and we know that it's poorly responsive to antiviral therapy, but it resides in B lymphocytes. It's most associated with things like HIV infection, B-cell malignancies, and lymphoproliferative disease. So knowing that it resides in B-cell lymphocytes, people have tested the ability of rituximab to help treat the underlying Epstein-Barr virus. Rituximab targets the CD20 antigen on B lymphocytes, And their role here is to have B-cell cytotoxicity in hopes of reducing the viral load of Epstein-Barr virus. Looking at Erlanger's lovely order set for rituximab, it includes things like pre-medications for infusion-related reactions. It includes things like acetaminophen, diphenhydramine, and methylprednisolone. And then for its actual dosing, it's dosed at 375 mg per meter squared, and you start the infusion at 50 mg an hour. If patients don't have any infusion-related reactions, and by this I mean anaphylaxis and hypotension, you can increase your dose every 30 minutes up to a rate of 400 milligrams an hour. If they tolerate it all the way up to this dose, then next time you give rituximab, you can go ahead and start at that higher dose. Your order set also includes things if they do have an infusion-related reaction, including LR, albuterol, and famotidine and epinephrine. So monitoring, we would look for those infusion reactions, and they do recommend getting hepatitis labs before you start the therapy. To back this up, I'm not going to go too in depth of this study. This was a pediatric trial that did the same dosing regimen weekly for 2 to 4 weeks to try to help reduce the viral load of patients with Epstein-Barr virus HLH. Most patients received an average of 3 infusions, and what they saw, what I'm showing you here, is the pre-treatment and post-treatment differences. So they saw a decreased Epstein-Barr virus load. You can see pre-treatment, it was 114,000 copies, but after treatment, it went down all the way to 225 copies. That was statistically significant. Same thing with our ferritin levels. We saw a statistically significant decrease in those as well. All patients did, however, receive concomitant etoposide and dexamethasone. A lot of them, 62%, also received antiviral therapy, and 48% underwent stem cell transplant. I hope y'all didn't forget about our sweet patient. All of our labs came back. Everything that we sent out came back. He does have a positive H score of 189, and he does have a positive HLH score of 5 out of 8. Thanks to Kyle and Mitch's workup, we found that he had 1 million copies of Epstein-Barr virus. This is the real treatment based off this patient case. What they decided to do was give dexamethasone 10 mg per meter square, exactly like the HLH-94 protocol. They gave etoposide, a little bit lower than what they gave in the protocol, so 50 to 100 milligrams biweekly. Rituximab, they gave given the Epstein-Barr virus to try to reduce that viral load in the B lymphocytes, and then they gave ganciclovir. So I just presented a lot of information about a lot of different subgroups, but so I wanted to give you my proposed treatment of what I think you should do if you have a patient with secondary HLH. So if you suspect that your patient has HLH, I think giving dexamethasone is maybe one of the only common denominators among all of these studies, and it's pretty low risk when you're comparing it to something like etoposide. I also think that we need to emphasize treating the underlying cause in these patients. If your underlying cause is MAS or related to an autoimmune disorder, I think you have your most evidence for anakinra and IVIG here. If your patient has malignancy HLH, I really like the idea of incorporating etoposide to your chemotherapy regimen if you're going to do something like that already. If you have Epstein-Barr virus HLH, I do agree with the addition of rituximab in addition to treating your underlying cause. Things that I think are still on the horizon, if you have refractory disease, I think we can push our anakinra dose way up beyond the 100 milligrams TID. I think ruxolitinib still needs a little bit more data, but overall shows a potentially less toxic option than our HLH-94 protocol. And then very, very last, I have etoposide. I would not give the full 150 milligrams per meter squared, just based off the fitness and probably many comorbidities that your adult patients are likely to have. So I think depending on your patient's underlying cause, you potentially could consider. But that concludes my presentation, and I'm happy to take any questions. I'd like to thank Tia and Jesse for their help with the CE creation. Huh? Do we have a question? Yes, Jesse.
Hi. What would you do if your labs were indicating that your patient might have HLH, but you hadn't necessarily ruled out?
Yeah, I think that's a good question. So the question was, what would you do if your labs for your patient are indicating that they may have HLH, but you haven't ruled out infection yet? I would say rule out your infection first. We know that sepsis and septic shock have a lot of clinical overlap. And you can have infection and HLH at the same time, but if you don't identify and treat the underlying cause, you're potentially delaying the resolution of the HLH anyways. You have more questions? I feel like you have more questions.
I have a question.
Okay, what's up?
What would you do if you didn't know what the underlying cause of HLH was? I know you had like dexamethasone sort of a breakdown, but is there anything else that you would add to someone if you weren't sure what their causative mechanism was? Sure.
Let's go back to our algorithm. So Jesse's question was, is there anything else you would consider adding if you didn't know the underlying cause? So I would say if I haven't ruled out infection and we're send out labs, I think it's appropriate to keep them on like therapy based off highest suspicion of what you think the infection was. So I'm assuming we're getting pan scan, we're sending out all of the things. But until we're able to rule those out, I wouldn't discontinue any anti-infectives if we think that infection is the cause. If it's autoimmune, steroids are oftentimes the treatment of autoimmune processes anyways. So like I said, that's why I think dexamethasone is one of the great, like more empiric treatments of HLH that is relatively low risk that you can give many of these patients. Now, Epstein-Barr virus is a little bit more tricky. You'd have to have higher suspicion. I wouldn't just give somebody rituximab without confirming that they had Epstein-Barr virus. Does that answer your question? Anything online? Okay, thank you guys. Do what? No. I can be. Let's see. You mean go to like Outlook Online? Is it in the like invite? Okay. Oh, I can pull up the title thing after.
Yeah.
After we get the code up here.
Yeah, great. No, no, no,